Shouldn't be terribly difficult for us to work through. It's a lot of slides, but a lot of pictures. And a lot of these illnesses that we'll talk about do have just kind of an overall sense of familiarity. And so I think we'll be able to work through it pretty straightforward. A lot of pathognomonic stuff that'll help us out as well. We'll get you guys through this, and I doubt we'll take the full 2 hours. And then tomorrow, if I'm tracking correctly, y'all basically have just a study day, right? Like no classes tomorrow because of the APR. And then Thursday, do we get it switched okay with Dr. DeBoer? I'll come in at 1300 and have some review stuff up for you guys and ready for you guys. If you can, I know it's difficult, if you can carve out a little bit of time tomorrow just to kind of, even just a once through the slides, something to kind of review where we were at for Block 2 material, I think that'll give you a much better vector check for where you're at and what you need to do for the test. Coming up next Tuesday, right? We have Monday off? Yes. All right. When you look at this list, so it's weird order. I can't help but not put MMR together because it's a vaccine and it's split up on this list, so it bothers the OCD person inside of me. But we'll talk about mumps, measles, and rubella, CMV, mono, poliomyelitis, heartbreaking disease, varicella, herpes, and erythema infectiosum, roseola, and Zika. Anybody remember the big Zika scare about 7-8 years ago? Real bad. All right, measles first. What does the R in MMR stand for? Rubella. Notice, please, that measles is called by many as rubeola. It's not rubella. However, just enough overlap of sounds and letters that it could be easy to get mixed up. So please kind of make the mental note, take the time to make the mental note that measles and rubeola are the same thing. Measles and rubella are different things. Okay. Droplet contact, very communicable. And then if you look at these kind of symptoms, fever, conjunctivitis, coryza, and cough. Coryza means what? You guys remember? Yeah, the mucus inflammation of the nose specifically, so a stuffy, runny nose, for lack of a better description for coryza. So it's going to come across as just a pretty standard upper respiratory tract infection, common cold type of symptoms. However, anytime that you have something that says pathognomonic or that you find out is pathognomonic, like it's very specific to that disease, just throw that into the memory bank. Because how many diseases that we've talked about have cough, nasal congestion, watery eyes, and a fever? Like all of them, right? And so once we can start to tease out some of those very specific things that go with one disease pathology as versus other, important just to go ahead, circle, star, underline, whatever you need to do. So Koplik spots are small spots on the buccal or buccal. Some people say buccal, some people say buccal mucosa. Where is that located? Inside the mouth. Inside the mouth. So the inside of the cheeks is the buccal mucosa. Here's an example of it. Zoomed in enough that it may not be the easiest to appreciate, but the perspective there is kind of looking at like the inside of the cheek with the oral cavity open. You see those little white dots. Those would be Koplik spots. So pathognomonic, meaning if you have them or you see them, the chances of it being measles or rubeola extremely high. A couple pictures there. There's also a red blotchy rash. It tends to begin on the face and spread to the trunk and extremities. Sounds like half the rashes we talked about, doesn't it? And so it is there. It can become generalized. If we do some lab work, leukopenia is there. Please note here on the fourth main bullet down, sometimes you can get a desquamation of that rash. What does desquamate or desquamation mean? Starts to like peel off, right? Have we talked about other rashes that peel off? Yeah, right? So please take the effort to make sure that you're understanding some of the things that separate these two. So measles or rubeola starts with kind of upper respiratory tract infection type stuff, has a rash that starts on the head and moves to the trunk, can desquamate, but those Koplik spots are things that can be something that truly differentiates it from other viral infections or bacterial infections. A couple pictures here, sort of this rash and how systemic it can get. All right, it typically hands in populations where immunization to it, most commonly from vaccines, is not prevalent. In non-immunized populations such as underdeveloped countries, There can be a high incidence of measles, and it can have a higher fatality rate, especially in that population. Unique to measles, I shouldn't say unique. Not unique as in like it's the only one, but common. If somebody has a vitamin A deficiency, the measles will have a significantly worse outcome in that individual. Is it common for somebody in just North America to have a vitamin A deficiency? No, we have pretty good diet, pretty good nutrition, roundabout. It's in these underdeveloped countries where they have vitamin deficiencies of different types because the diet or whatever might be very restrictive. If they get measles on top of a vitamin A deficiency, it can be particularly bad for that individual. Some complications second to this, because there is a virus that's spread throughout the body. There's inflammation all over the place. People can get an otitis media, pneumonia, croup, diarrhea, encephalitis. All of those are possible secondary complications. And it's more severe inside the infants, the very young, or the adults, a little bit older. Death rate 1 to 2 in about 1,000. Not super worried that you know that. Let me rephrase. I'm not worried at all that you recognize that number at all, but it gives you an idea of kind of the prevalence that we're going to see in the U.S. And here's a picture of that more significant rash that happens. That can display made a little bit. All right, diagnosis typically made just on clinical and or epidemiological grounds. So for example, if you're in a place where it's endemic, you see the symptoms, you see the topic spots, you see the rash, for the most part you can just make that as a clinical diagnosis. If you want to pull some lab work, you can look for measles or rubiola IgM, which is the antibody to it. And IgM is always produced in what, the acute phase or the chronic phase? Acute, right? So we can know that they're going through something acutely, and if it matches the measles virus, then it can be a confirmatory type of thing. The communicability or the transmissibility. One of the things that I found very interesting, and it helped me understand why things get spread so easily, especially with viruses. If you look at this bottom section where it says communicability, that first bullet is it's very transmissible before the prodrome. So what symptoms are they experiencing before the prodrome? None. And this virus is in the body, it's replicating, it's shedding, it's being spat out, sneezed out, touched out, whatever the case is. The person who is sick does not know they are sick yet. And so they're just going through life kind of doing their normal healthy people things, spreading the disease unbeknownst to them. So it helped me kind of understand better why it's so easy to transmit, because for the most part, if you've got somebody who's sick, I feel like the kind of overall feeling is I'm sick, stay away from me, you wash your hands a little bit better, or you recognize someone else is maybe sick, maybe you keep your distance a little bit. But it's the fact that they just simply don't have symptoms yet. We don't recognize that they're not feeling well. A little bit more communicable. And that's pretty common. Almost every viral illness will be a bit more transmissible prior to the prodrome because they haven't mounted that immune response yet. Anybody who's not been immunized is susceptible to it. If there is a maternal antibody, it can interfere with the vaccine. And so immunization at 15 months is a pretty good idea. That way, the vaccine actually has a chance to get into a younger person's body that's not relying on the maternal antibodies, mount the response, and keep them safer more down the road. Prevention, immunization is helpful for sure. Persons that are non-immunized, treatment. Immunoglobulin is possibly a question there. And if we already know vitamin A deficiency leads itself to a very much more problematic disease course, so offering them for vitamin A may be helpful as well. All right, rubella, not rubiola. Rubella is what we're talking about next. It's a mild febrile disease. There is a kind of a faint pink, light red rash. Again, begins on the face, works its way down. Doesn't that sound like rubiola as well, kind of what we just talked about? Not a whole lot of difference yet. Kind of resembles the scarlet fever rash, mono or Coxsackie rash. We'll talk about some of those later. Here's a kind of a picture of it. It's a pretty kind of non-specific rash. It's pretty overlapping in presentation to several other viral dermatoses. Children, relatively few constitutional symptoms. Adults may have a couple days of a prodromal period. And look right there, coryza, headache, conjunctivitis, malaise. What does that sound like? Measles or rubiola, which we just talked about. So far, what's the only real difference that we can see between the two of them? The complex spots, right? And so it's important to kind of recognize some of those differences. Here's a picture of that conjunctivitis. Can you guys appreciate on those eyeballs just looks a little bit wetter and goopier than normal, even though it's not truly red or purulent. Here's something that is a little bit different about rubella. It's not completely pathognomonic. It doesn't help. Lymphadenopathy in rubella patients is really common post-auricular. What part of the body is post-auricular? Right behind the ears. And so for whatever reason, rubella tends to inflame the lymph nodes right behind the ear. And there are certain lymph nodes that tend to pop up in regards to certain diseases. So it can help us clinically kind of say this is more likely this than that. And then look at the very bottom one, Forsheimer spots. These are small red spots on the soft palate. How stinking tricky is this, right? Got a rash on both, got a fever on both, they both have R's in the names, and they both got spots inside the mouth, right? Like, it takes just a little bit of work to recognize the different, just to find differences, and it'll help you out a lot. So complex spots, where are they located in the body? Pupil mucosa, Forsheimer spots, on the soft palate. One is measles, and one is rubella. And post-auricular lymphadenopathy. And here's kind of a picture of that soft palate that has those spots on it. All right, some complications. It can cause arthralgia and sometimes arthritises. For whatever reason, it tends to hit younger adult females in terms of the arthralgias and the arthritises. Encephalitis is possible as well. Leukopenia, thrombocytopenia can occur on the labs. Again, not specific to the diagnosis, but we can see that as well. Identification of rubella is pretty important, especially if we have a pregnant individual who might have it. There's a lot of fetal anomalies or abnormalities that can happen from vertical transmission of it. Fetal defects is higher, especially if it is early in pregnancy that they get it. And so it's a good idea for individuals, if they are willing to get the MMR vaccine early in life before they end up pregnant. Congenital rubella syndrome is a possibility if a pregnant individual gets the rubella infection while they are pregnant, especially earlier on in their pregnancies. Fetal infection is a great risk. Injury and death is a possibility. Spontaneous abortion is a possibility. And then if they do deliver to term and have a living baby, some complications, deafness, cataracts, microphthalmia, and glaucoma are all in play there as well. Anybody know who Fetty Wap is? Y'all know he has one eye, right? Y'all know why he has one eye? Congenital glaucoma. So I don't know if it's related to this disease specifically, but the reason that the one eye, and he was supposed to, he says, both of his eyes, by statistical likelihood, were supposed to be affected, but for whatever reason, one eye was saved. But yeah, congenital glaucoma is why he lost that eye. You know what his vision is, right? Fetty Wap's? It's 1738. Joking. All right, CRS, congenital. Y'all want me to leave the jokes off the table? I'll leave it. No, keep going. You don't get it? You have to understand pop culture. We can talk offline. CRS considerations. So congenital rubella syndrome. Can have microcephaly, encephalitis, retardation, cardiac anomalies, spasmodilators, like just lots of things can happen to this poor little child if mama gets it while she's pregnant. Some pictures of the viral example of these babies from the vertical transmission. All right, some pregnancy considerations, again, milder cases may not be recognized for a long time, and somehow we have correlated type 1 diabetes to possible relation to infection as well. Can be very difficult to recognize clinically, because how many other disease processes does rubella look like? A lot of them, right? And so a high index suspicion is cool, very helpful. And look, we can test for the antibodies, and the IgM can give us an idea that they're acutely infected and mounting an immune response to it. And then if we do serial IgM levels, we might see an increase in the titers just because the body is producing more white blood cells to fight it off. If you're interested in trying to figure it out in the newborn, cerebrospinal fluid might be a body fluid that gets tested. All right, occurrence, it's endemic worldwide, has a prevalence for winter and spring, typically a disease of childhood, and humans are the only reservoir for it. Nasopharyngeal secretions are the mode of transmission. And the communicability, again, it's before they're even symptomatic that they can spread a little bit. I mean, it can while they're spreading and after a little bit as well, but it's the before they are symptomatic that it's the problem. If they become immune to it, if they do have permanent immunity, and then you see at bottom bullet, if you have a pregnant individual that has not been immunized to it, do not recommend immunization while they are pregnant. All right, cytomegalovirus. We've talked about CMV a couple different times. What's kind of cytomegaloviruses or CMV's kind of claim to fame, if you will? It's an AIDS-defining illness, especially in a certain part of the body. And so if it is an AIDS-defining illness, what kind of correlation can we make to otherwise healthy individuals? High susceptibility for CMV or typically pretty low? Pretty low. If we have an otherwise healthy individual with a decent immune system, pretty good ability to fight off CMV. You see on the right of the first bullet there says is HHV, that's human herpes virus number 5. So some people interchange them, CMV and HHV5. We'll just use CMV in this class. Pretty rare. The most severe form of the virus happens in infants when they get it. I mean, they say that. I guess a good argument could be HIV positive person having pretty bad outcome. And you can see the findings there: lethargy, convulsions, icterus, petechiae, purpura. Remember, it hits the kidney and the spleen pretty hard. Liver and spleen, my apologies. Liver. CMV survivors, especially if they're younger, they could end up with some mental retardation, microcephaly, hearing loss, motor disabilities, and possible even chronic liver disease. If it happens in utero, they may not survive. If they are HIV positive, you could end up with a disseminated infection, pneumonia, retinitis in the GI tract, hepatitis, lots of problems because the body's just not able to keep it in track. And this is a picture of a retinal exam of somebody who has CMV or cytomegalovirus-related retinitis, and you can kind of see how it's tracking down some of the arteries and nerve roots, inflaming that retina. Probably a good mix of vision disturbances as well as pain happening with this individual. We can isolate the virus in the ear in the newborns. If it's an adult that we're trying to work up for CMV, a little bit more difficult to recognize. There is an antigen and a DNA detection available if we want. Happens worldwide. It's excreted in urine, saliva, breast milk, semen, and cervical secretions. Humans are the only known reservoir. They can be transmitted through intimate exposure, mucosal contact, and then just simply contact with secretions or excretions. And we know that little kiddos, this is different than the intimate stuff, just in general, little kiddos share spit, saliva, sneeze on each other pretty commonly. It can be excreted for quite a long time. It can persist for a while. Susceptible is nearly universal susceptibility. It's kind of all over the place. Prevention and treatment-wise, good hygiene and sanitation will help it. If somebody gets sick and if we know it's CMV, an antiviral can help. So Valgang, gang cyclovir, or Forscarnet are a couple of options that are antivirals that people may respond to. All All right, Epstein-Barr virus, more commonly called mononucleosis. Anybody know the more lay term of it? Kissing disease. I had a girlfriend once who got mono while she was my girlfriend. I didn't get it. I know what that means now. So I grew up homeschooled and wildly sheltered. So I did not understand a whole lot of things in that regard. She was just like, no, I'm sick, don't worry about it. I drank out of someone else's cup. All right, acute viral syndrome. This one, people have really sore throat. They have something growing on the throat, typically an exudate growing on the throat. But for whatever reason, this one tends to make people much more tired than most viruses. Now, viruses commonly make people tired. That's a very common thing. But this is like excessive fatigue. People really get zonked pretty bad when they get mononucleosis. Here's an example of some of that exudate that can happen in mono. All right, is there another condition we've talked about that has sore throat, tired, fever, and an exudate on the throat? Strep throat, right? Group A, beta endemic strep. And so these two are classically on the differential for each other. So when you're seeing test questions, get bit by it, you have patients with it. Mono and group A strep are commonly considered at the exact same time because the clinical presentation is quite similar. What's one thing that's super unique about group A strep that is not as common symptom-wise? Lack of cough. And that's one of the things that when I was in clinic, people would come in with sore throat, laryngitis all the time. And they would always say, I'm here because I have strep, just give me my antibiotics, I'll make this a really easy appointment on you. And it's, as you go through your antibiotic stewardship classes, you'll realize it's not always as easy as just that. But one of the things that I would love to ask, just because it was very delineable, is I would say, oh man, I'm sorry you're going through that. I bet that's really bad. Is the cough really bad for you? And because they want to make themselves feel as sick as they can to the provider so they can get their antibiotics, it was almost unanimously, absolutely, the cough's terrible, it's keeping me up at night. And I would always respond with, thank God, that means you don't have strep and don't need antibiotics. And they absolutely hated it when I would say that. Because people with strep don't tend to cough, and so if they have a real bad sore throat, swollen lymph nodes, got something growing on it, and even they will feel confused by it. They're like, yeah, I'm really sick. I don't know why I'm not coughing. That doesn't make sense to me. Then I would be a little bit more concerned. I was like, all right, I think you got an actual bacterial infection we need to treat for. But if it's both on your differential, someone has a pretty strong cough, not a guarantee, definitely not a guarantee. But people with group A strep don't tend to cough, and most other pharyngitis tend to have a cough, if for no other reason, just because the pharyngeal irritation is very off-putting, and people constantly have the feeling that they need to clear their throats. All right, fever, chills, malaise, fatigue, and look at that 93%. That's saying like 93% of people with this report it, but it's also known for just causing a lot of fatigue. Severe sore throat can have a prolonged recovery and a little bit more milder, but also difficult to recognize in a younger patient. Jaundice can happen. It's not a guarantee. It can't hit the liver. However, there's not always going to be LFTs out of life. Possible connection to Burkitt lymphoma and nasopharyngeal cancers. There's no definitive word on that, but there's some thought that those two could be related as well. Very rarely fatal, for the most part, symptomatic treatment. Some labs that might help us, lymphocytosis, abnormal LFTs, if they're going to be abnormal, could help us a little bit. And then while we have the rapid strep test, a monospot, if you ever hear people say, let's do a monospot, that is similar to the rapid strep in that it's commonly done in the clinic to help delineate the difference between do we have mono, Epstein-Barr virus, or do we have group A strep in our individual. So monospot is a pretty commonly used test when it's a little bit not positive what's going on with the individual. All right, HHV4 is the other name for Epstein-Barr virus. We will call it mono and or Epstein-Barr in our class. Person-to-person transmission, usually through the oral pharyngeal route. That's why some people call it the kissing disease, because a lot of people will be infected with it, not know that they're infected with it, and kiss somebody, and spread the disease that way. So I had some young kiddos when I was going through IPAP, and then shortly after that we had our last one. After taking this class, I would not let a single person kiss my child. I was like, no, you're in. And you're not allowed to. And so a lot of the old ladies at church were pretty mad at me, but I didn't care because I didn't want anybody to give them Epstein-Barr virus. 4 to 6 weeks is the incubation period, very prolonged communicability, and then the pharyngeal virus excretion, that is typically the route that it gets transmitted to somebody else. The infection itself has a high degree of resistance, and there's not a lot of immunity that is presented after it. A lot of ways to prevent it is good hygiene, good rest, and then symptomatic treatment when somebody has it. Just help their immune system get over it on their own. All right, mumps is the next one. Y'all hanging in there okay? I get it. It's a lot of information, right? Just memorize these words with these things. I get it. You guys are going through a lot. Appreciate all you do. I can slow down and throw in more stories if you guys want me to. No, that's good. Mumps. So again, MMR, mumps, measles, rubella. We talked about measles and rubella so far. Mumps is the other M in part of the MMR vaccine. It's an acute viral disease that does have a fever, swelling, and tenderness, and this one tends to be pretty common for the amount of swelling that it gives and the location of some of the swelling and the pain. It tends to affect the lymph nodes and the parotid gland a lot, so you'll get a lot of individuals with really significant neck and face swelling. It could be unilateral and it could be bilateral. Those parotid glands just swell up like crazy. Anybody watch Brooklyn Nine-Nine? There's a pretty famous episode where Captain Holt and Jake Peralta get mumps and they have to quarantine together. And they saw their doctor, who, by the way, was Oscar from The Office. Right? And he says, you're going to have extreme swelling and extreme testicular pain. And Jake Peralta goes, sounds great. And he goes, what part of the extreme testicular pain didn't you understand? So yeah, pretty funny episode. But mumps, lots of swelling and fever. The orchitis and oophoritis that it talks about in the middle of the page is swollen, inflamed, painful testicles or ovaries. For whatever reason, mumps hits that reproductive organ, and it can cause a lot of pain and swelling as well. A lot of fear for sterility with this because of the swelling and the pain to the reproductive organs. However, it's found that sterility is relatively uncommon. Pancreatitis can happen, and mortality, not super high, about 1 in 10,000 cases if they get it. Pretty recoverable, just these individuals tend to be quite symptomatic. They tend to be in a lot of pain. All right, some neurologic involvement, and we talked about the orchitis as well, may occur with or without the salivary gland involvement. There can be permanent nerve deafness. It's rare, but it can happen. And some other neurological conditions, neuritis, nephritis, arthritis, thyroiditis, mastitis, and pericarditis. So it can itis a whole lot of different spots in the body. Mumps is pretty impactful. If a pregnant individual gets this, they could have a spontaneous abortion in the first trimester. There is no evidence to recognize specific congenital defects if they are able to carry the baby to term. All right. My apologies, guys. I had a story to tell you, and I decided it wasn't the right time to tell you. Unless y'all want to hear it. I think that you guys are tired of my stories, though. No, you want to hear it? My sister-in-law's having a miscarriage, and it made me think of that. Right? Y'all asked for it. Y'all asked for it. I wasn't going to tell you. I wasn't going to tell you. Well, that's why I was sad for a little bit. Y'all didn't see that I got sad? My brother-in-law, who's one of the coolest dudes ever, married a Ukrainian woman, beautiful person, phenomenal individuals, had the cutest little baby, this gorgeous little blue-eyed baby. His name's Everest. It's just one of the coolest kids I've ever met. Found out she was having another baby, which is super cool, and then they went to have a checkup, couldn't find a heartbeat, got a second opinion, couldn't find a heartbeat. Now she's working through the stages of that. My sister, who has had multiple miscarriages, just found out she's pregnant and didn't tell anybody until she's in her second trimester. So we're pretty sure that one's okay. So, and my sister is a super duper workout freak. She's just like so strong and so thick. I'm like, please have a baby girl so that we can teach her to play rugby, and she could be like Alona Mar. And if you guys don't know who Alona Mar is, you ought to go look her up because she is an absolute badass. Who knows who Alona Mar is? Am I wrong? Dude, can you imagine having a rugby ball, whatever they call it? They call them footballs in rugby? It's a rugby ball. Can you imagine her barreling down on you with bright red lipstick? Like, just, oh man, I'd be like, here, please take it. Do whatever you do with these things. Listen, y'all asked for the story, and we went all the way to rugby. So mumps, relatively rare compared to other childhood diseases. They can be quite, a lot of them exposed can be subacute, meaning it doesn't actually get them sick enough to get seen. Winter and spring a little more prevalent. And adequate immunization programs within certain populations do help the disease transmission of this. Y'all are never going to say yes to a story from me ever again. That was a wild ride, wasn't it? Like, imagine just living inside this brain. Like, who knows where the carousel's going to stop? Okay, mumps, droplet transmission, direct contact with the saliva. Again, I wouldn't let anybody kiss my babies because I didn't want them getting any of this stuff. And just the pictures there that you see, I mean, that's a really robust swelling, is it not? Like, that's pretty palpable. Like, I have to imagine those individuals are in just a significant amount of pain. Isolated in the saliva, and a lot of parotitis, parotid gland inflammation. And again, maximum infectiousness is before the actual illness starts. Typically, immunity is lifelong once they have immunity. And that statement there about people born before 1957 likely to be immune without history of illness probably were subacute infections and built up immunity to this one. All right. Poliomyelitis or myelitis. You guys heard of polio? People talk about it. That's what this is talking about. So polio is poliomyelitis. There's kind of a really famous medical device that became famous because of polio. The iron lung, right? The iron lung. Polio, man, wildly bad. Thank God that we do not see this anymore. Pray it doesn't come back. But it gets, we'll talk about it. It gets in there and it causes muscle paralysis. There are a couple of muscles in the body that are really, really important, right? Like leg muscles, really important. There's a couple muscles very specifically that can't ever stop working, the lungs and the heart. And so if the the diaphragm gets impacted, the chest cavity gets impacted with the paralysis there, the individual can't breathe on their own. And so the medical device that was created during the polio wave was the iron lung. It created a capsule that somebody would lay in. Negative pressure would basically inflate the individual's lungs for them, and they lived inside that iron lung until the end. There was no recovery from it. And so what's that? Last I heard he was still alive. Has he passed away? I don't know the answer to it. I know that recently I saw something that there was only one more individual still living inside. It was a pretty old individual, if I remember correctly. But yeah, so I mean, it worked, and I am thankful for medical advancements that help people out. But yeah. All right, the viral infection. This one is kind of famous for its rapid onset of flaccid paralysis. So just all those muscles go limp. What's unique about this paralysis is the sensation is still intact. So imagine not being able to move any of the muscles that are impacted, but you still have sensation in that extremity or wherever that is. So you can still feel pain, feel cold, feel heat, whatever the case is. Wild, isn't it? Just some examples here of individuals. And a lot of times it's unilateral that it affects. And it really doesn't affect the legs as much as it gets into the central nervous system, either the brain or the spinal cord, and it'll destroy nerve roots there. And that's why the individuals will get a lot of flaccid paralysis because of where it's being impacted. The infection starts in the GI tract, spreads to regional nodes, and then to the nervous system. And flaccid paralysis occurs, about 90% of the infections are subacute. In other words, they tend to get over them without needing medical intervention. Aseptic meningitis is possible. It's in the nerve system, it's inflaming. And we're talking about a virus, so it doesn't make sense to call it aseptic meningitis, because you would think, well, there's some type of infection. Really what it's inferring here is the central nervous system itself is not necessarily infected, but there is a polio infection happening with them. If you hear people say abortive poliomyelitis, what they're talking about is a polio infection that got better on its own. It aborted itself, it's fit within itself, typically pretty mild. Then there is non-paralytic. This is where the meninges are irritated. They can have muscle spasms, but it's kind of in the middle ground of how serious it actually is. And then paralytic poliomyelitis, again, it gets into the spine or the bulbar region of the central nervous system, and it impacts those nerves significantly. A couple pictures, again, unilateral attack, paralysis there. The extent of the paralysis just kind of depends on the virus, how bad it attacks the central nervous system, and the nerves that are actually impacted as well. Spinal cord, brainstem, all can be involved, and then the legs tend to be affected more than the arms are. Some pictures of individuals impacted by polio. Life-threatening paralysis, especially if, depending on what gets paralyzed, right? If the diaphragm gets paralyzed, they can't breathe, they need somebody to breathe for them. Guillain-Barré syndrome is on the differential when you have this. Anybody remember much about Guillain-Barré syndrome? We're not talking neuro in here, you'll talk about that more in neuro, but what tends to be present with Guillain-Barré that's a little bit different than what we just talked about? So Guillain-Barré tends to be bilateral, and polio tends to be unilateral. Guillain-Barré tends to, not always, be bilateral and kind of work towards the proximal section of the body, and polio tends to be pretty rapid onset and unilateral. All right. The non-paralytic differentials, again, because it's impacting the nervous system, and you'll see potentially muscle spasms, which could look like seizures, and meningeal irritation, which can be very painful. On the differential, this is not saying that it causes, but you have to think brain abscess, neurosyphilis, leptoencephalitis, or even infectious mono. All right, the virus can be isolated in stool, cerebrospinal fluid, or pharyngeal secretions. And a lot of times, there's a presumptive diagnosis made when there's a fourfold rise in the antibody titers. All right, before the immunizations, it was all over the world. The immunizations have significantly improved prevalence of this disease. Thank God. Humans are the reservoir, person-to-person contact, fecal, oral, and or pharyngeal spread. Communicability, we don't really know. The polio virus does help. Here's some examples of some polio eradication efforts. The treatment for this, there's really not a great treatment for the virus. The body tends to do okay with it. It's the attack to the nervous system with the secondary paralysis that tends to be the problem. And at that point, we're just trying to get the body to work again. So a lot of physical therapy, mechanical therapy, respiratory therapy may be at play to help individuals depending on how severe their paralysis is if they were in fact paralyzed. All right, how do you say that word? Okay. All right. I got laughed at a lot by the other day. I mean, to be fair, I earned it, right? I called it varicella, and they said that I sounded like an Italian when I said it. The reason I call it varicella is because the guy who taught me about it called it varicella. I don't know why he decided to do that, but it stuck in my mind. Please know, most people don't call it varicella. So if you hear me say it, I am probably the idiot in the room. Call it varicella. It will make you look like less of an idiot. Actually, you guys don't look like idiots at all, but you'll look much more educated than I did on accident. So varicella, also known as chickenpox, it's a generalized viral disease. It's pretty well known, and there is an immune vaccine for it. A lot of individuals are nervous about the vaccine, and there are still pockets of people who try to have their children exposed to it when they're young, healthy immune system naturally, to build up a natural immunity. Were you the one telling me about the chickenpox party which you went to? Do you want to tell your story? So those who couldn't hear, he was taken to a chickenpox party to purposely get chickenpox to recover from it, right? Got a secondary infection from one of the pox lesions. Staph infection turned into neck fash. Were you in the hospital? Were you hospitalized for 3 months? Hospitalized in the hospital for 3 months. Secondary to neck fash. So, did you use skin graft? 4 skin grafts. So when we were talking about neck fash the other day, if you want to know more of a first-hand story, if you'd be willing to share it, you can ask that. I know when I was a child, I got chickenpox, and it did have a very bad case. I thought it was so weird that all of my friends got to come over when I was sick. Mom had never let my friends over when I was sick before. I was like, this is the greatest disease ever. We were on the trampoline. We were playing Nintendo. She's like, who wants pizza and Kool-Aid? And I was like, obviously me. Now I know what they were doing. So the whole church got chickenpox. Same day. Someone said, the whole church got chickenpox. That opens up a lot of information about them. Varicella is what it looks like under the microscope. The skin eruptions is kind of what it's famous for. It begins as a maculopapular rash. Those papules then turn into vesicles. The vesicles rupture and scab over and should heal. If there's a complication in the middle of that natural progression, bacterial infections can get into the skin from irritations and or secondary exposure to bacteria, or people irritating it. There are some that have such a robust dermatosis from it that they have real bad scarring from their chickenpox and stuff like that. It can get that bad. And I remember even thinking it was weird. I only had one pox when they had our, I guess, chickenpox party. I had one, that was it. But like my brother had a billion, and I thought it was cool because I didn't like it very much. It's okay, you can laugh. But we all recovered from it. This picture of the vesicles. They commonly occur in crops, so they're kind of clustered together. And we talked about smallpox. The lesions of smallpox are synchronous or asynchronous? Synchronous, right? Chickenpox, you will see them all over the body, and they'll be at different stages or asynchronous of development. And if you kind of look at this individual, the vesicles here, some look old, some look new, some look scabbed over already. They're at different stages of development. All right, locations. Very commonly on the face and head. They move down towards the trunk, so it gets into the axilla. It can hit the mucous membranes of the mouth. Very painful if it does so. And then we talked about even varicella can cause a pneumonia. The virus itself can cause a pneumonia as well. If you look at this individual, it tends to be really clustered, heavily prevalent on the neck and face, and down to the trunk. It is still definitely on those extremities, but tends to start to thin out a little bit on the extremities. There can be a pretty high fever and constitutional symptoms, especially if an adult has it. If you guys haven't heard it, a lot of times you'll hear people who don't want to immunize their kids early. They'll say stuff like, I'll wait to see if they catch it naturally. If they don't, when they're a teenager or something like that, I might give them immunization. Varicella tends to be one that if a non-exposed or non-immune individual that's an adult gets exposed to it, tends to be a bit tougher of a case to recover from. Here's pictures of those pock lesions in the oral mucosa. It can cause pneumonia, encephalitis, and congenital malformations if a pregnant individual was to catch it. An example of somebody, a baby who got it. There's pock lesions all over the face. Here's someone who has an adult who has a pretty diffusely, obviously a significant constitution. I am going to make an assumption by the picture that this person has some type of respiratory compromise secondary to the virus. If you just look at this, you can see the asynchronous development of these lesions. It's connected to Reye's syndrome. You guys remember talking about Reye's syndrome? Aspirin, a virus, and what organs, two specifically, that tend to be hit pretty hard by Reye's? Liver and the brain. You guys are smart. You're awesome. Varicella can predispose somebody to getting shingles later on down in life. That one's caused by herpes zoster. We'll talk about that one here shortly. They'll get over the varicella, That varicella will recover. However, the body isn't able to completely eradicate it, kick it out of the body. It kind of goes and lives in a dorsal root ganglion within the central nervous system, and it just hangs out there for the rest of its life until there's an opportunity for it to kind of inflame up and track down that nerve root. We'll talk about that in a minute. Let's take a break. We'll get started again in about 10 minutes.
At least like where you do it's too hard. You just go up and just Just jump up and slowly go down. Like this. Jump up, hold it, slowly let yourself down. You like kind I'm barely going down enough. Yeah. Locked in. Locked in. He's got that locked in syndrome.
My allergies are
I'm just trying to survive.
My eyes just watery and itchy. I'm like, I'm tired. Yeah. She will be. She has under trying. That's not double shit.
Are you sure? What do you think? Should I stop? No, just gotta
Tell her you
should.
The full hour that it's
You're not going to pay attention.
I don't pay
But you're like, yes, more stories.
because I listen, I pay attention when you take my
Stories. I'm like,
Yeah, I mean, just do it however makes it easier for you. Yeah. Trying to find a way to like narrow stuff down. So when you see a certain word, you know what it's talking about.
oh my god, I got my dress. But I don't like I got answered when I
Now I gotta charge the old laptop. I'll go back to
Gum. Late night. I got some starting. I'm trying to make like really good, not off the wall, very simple. I still had to figure out what that was. I was like, what's the music?
I was reading, I was like,
I got to bring it to the cushion. Thursday. Let's see what he says.
where are you going?
Everybody can go down here.
Especially good, like, did you see when
Mom said endo if you pay attention in class, listen to what she says when you know this. That's exactly what I am. He said he's telling me he's struggling. He's like, you might see me next semester.
It's like,
He's like, if I do, you're going to be sick of me next semester. I'm like, hell no, you're going to help me get through.
rearrange the room a little bit so that there's like, how do you recommend?
Which drug is good for raising HDL and bad in pregnancy? Nice. Raising HDL is good, but statins are also good.
All right, I'm going to start with an apology. I know that I tell stories, and I do my best to keep them in line. I in no way was trying to make fun of the situation where a baby might not make it or a miscarriage. So my apologies if they came across unprofessional in any way. Did I tell you the story about the patient I had who was having a miscarriage in my office that ended up carrying a baby to term? It's one of my favorite stories. Can I tell you that one?
No.
So, was that one? Was that?
It's a little bit more rare.
Right.
Yeah, like
Well, and I'm not the one in charge of anything, of course. And so I know that there are a lot of people who have different histories of individuals that had miscarriages. My own mother had a miscarriage, and had she carried that baby to term, I wouldn't have been born because she got pregnant with me right afterwards. So I know that life has its paths. It's not my job to say they are right or wrong, good or bad. But please know I was not at all trying to devalue that scenario or anybody who has gone through that. That's actually a difficult one. I was more annoyed that I was trying to teach you all a topic, and that was a thought that came into my head. It made me sad for a second. I had an individual, never met her before. She came in for cervical cancer screening or a pap smear. And she said, I don't think I can do this today because I'm on my period. And I said, well, we can try to do it if you want to. You can do a cervical cancer screening when somebody is on their cycle. The blood might obscure the cells and you might have to repeat it. So I usually tell them, if you want to try, we can. Maybe it works, maybe it doesn't. It's up to you. She's like, sure, let's give it a shot. She got into position. I went in to go ahead and insert the speculum to look at it. And she was not having her cycle. She was having a miscarriage. There were products of conception coming out of the cervical os. Like, no doubt about it. And so I asked her, I was like, are you regular? Like, do you cycle regularly? She's like, oh no, my cycles are all over the place. I get about two to three a year. And she was heavy set, had acne, and terminal hair on the chin. Anybody have any idea what disease I just described?
Cushing's.
Polycystic ovarian syndrome. It's an endocrine disorder that affects the female reproductive system pretty impactfully. Fun fact, they do not need ovarian cysts to have polycystic ovarian syndrome. They actually can have PCOS without cysts on the ovaries. But anyway, so like almost immediately I was like, well, I know what's going on. The truth is, it's a strong possibility she's been pregnant before, had a miscarriage, and she just simply considered it a delayed cycle or whatever the case was, right? So I was like, well, I am not an OBGYN, but I've done this a lot. Ma'am, I'm pretty certain you're having a miscarriage. Have you done a home HCG or anything like that? She's like, no, because I'm always irregular. I said, are y'all trying to have a baby? She goes, oh yeah, we've been trying to have a baby for years. We just can't have one. So I was like, hang on just a second. So the supervising physician on my team at the time was also a board-certified OBGYN and a board-certified family practice doc. So I was like, sweet, doc, need you a whole lot right now. Went in and told him the story, and he said, well, I'll go ahead and take a look. He took a look, and kind of he's an older gentleman, very, very pleasant. He said, ma'am, you are having a miscarriage. And I'm sorry to tell you that, but you're having a miscarriage. And we walked out the door, he and I did, and even though I was a practicing PA, had been for about 6 years, I was like, doc, I'm going to have to do some learning from you right now. Like, I don't see this every day. What do we do? And he said, understood, Kev. We're going to give him this medicine. It'll help expedite the process. She'll recover, and then she'll kind of go back into whatever her body is for cycling. You're correct. She has PCOS. Even if she doesn't know it, let's get her referred over to Endo and Women's Health, see if they can help her since she wants to procreate. I was like, you got it. It was so weird. He stopped. Like, he was starting to leave. I said, doc, will you take over this case for me? You know better what to order. You're comfortable with it. Will you take over for me? He goes, you got it. You see my next patient. I'll take this one from you, and we'll finish it that way. It's like, great plan. He stopped, like, mid-stride. He goes, hold on. I have never done this in my life before. But let's get an ultrasound. And I was like, so first of all, doc, you're really confusing me because you were real confident a minute ago, and now you're telling me that you're changing your mind midstream and you've never done this before. But, like, you're the doctor, like, whatever. He goes, let's get an ultrasound. I don't know why I'm telling you that. I don't know why I'm suggesting that. He called ultrasound. They're in the hospital. She walked over to the ultrasound department, had the ultrasound, walked right back, got the report. She had a viable pregnancy in utero still at that moment. Had they not done the ultrasound and just given her the medication, would have cleaned out the viable pregnancy as well. And he was like, I don't know how to tell you why I did that other than my gut just told me I needed to. And I was like, this is wild, doc. And you'll hear the word gestalt. Has anybody heard that word before? It kind of describes in medical practice a gut feeling. And while there's not really a lot of time to like, describe why it happens, in my opinion, just like you ever hear people say practice favors the, or luck favors the prepared, like just the ones who practice all the time tend to get lucky more. I think that gut feeling comes with just lots of experience, lots of practice. You don't always know why you feel the way you feel and you think, but something inside you is just saying, I think this is the right thing to do. And then when I did it, that lady carried that baby to term. It was awesome. Like, I didn't see her again. She wasn't my patient. We got her in with OBGYN like right away. They took really good care of her. That body somehow had recognized she was pregnant with twins. One of the fertilized eggs was non-compatible with life, was removing it, and the viable pregnancy continued on. She carried it to term. I saw her like 2 years later for some random thing, and she had a baby with her. I was like, that's pretty cool. Maybe Kevin, just kidding, she did not. But it was a super, super cool story to watch play out, and it absolutely gave me a moment of like understanding and confidence that like it's okay to listen to your gut a little bit, right? And as long as you're not hurting the patient, you're okay to do a little bit more work for your patient. And that's a super cool version of a potential miscarriage. Well, I can't think it was a miscarriage. She was having a miscarriage of the non-viable pregnancy. Anyway, so there's a much better story. And then also my sister's pregnant. I don't know if I told you that or not. She's probably going to get married, give birth to a very muscular princess. Man, I wish I was living in the same city. I would spoil that baby so dang much. Like, I would teach her how to play rugby. Yeah, it would be awesome. Okay, herpes zoster, also known as shingles. Most people have known somebody with shingles. What do you kind of remember about shingles? A very specific rash. Painful or not painful? Wildly painful. Believe it or not, there are some that can be painless, and those tend to be the harder ones to diagnose because you're like, why aren't you in pain? I have seen some painless zoster outbreaks as well. But shingles is what it's called. Herpes zoster is the causative agent related to the varicella virus. They will be exposed to this, they'll recover from it, and then that virus will just kind of hang out in some dorsal root ganglion. So cranial nerve all the way through 1, all the way down through S5. There is no guarantee of which one it's going to hang out on. It's going to no guarantee whether it's going to be right or left. It's going to pick one of those nerve roots. It's going to live in there forever. And at times of some type of stress on the body, I'm not talking emotional stress, it could be any type of stress, when the body's a little bit weaker, that virus says, now's my time to shine, the body's weak, and it'll kind of like amplify itself and just spit itself out all the way down that nerve root, and that's why you get that rash in the dermatomal pattern, because it follows that nerve root, whatever that nerve root is, and it'll go up through the nerves into its peripheral like little nerves to the skin and create a significant rash, secondary to skin inflammation that's been carried down by that nerve root. Is it a bacterial infection? No. It's not. Can it become secondarily infected with bacteria?
Yes.
That it can, and that's why we would be cautious and we would put antibiotics in that individual if there was signs of a bacterial infection. You guys already taught yourself this lesson. It's super awesome. What if that virus flares up, it follows a dermatomal pattern, but it crosses dermatomes? It crosses midline, it starts T1, but it goes all the way down to L5, like huge. What might that indicate? Immune system compromise. Immunocompromised individuals, cancer patients, on medicine, monoclonal antibodies, HIV patients, old, more frailer immune systems, they simply, one, can't hold the virus in the nerve root, and when it flares up and spits itself out down the nerve, dermatomal pattern, it can't contain it within that either, and it'll just like very robustly spread out significantly to surrounding skin. So if you see somebody with a very zoster-like rash, but it crosses the midline, it goes way up, way down, it's much more broad than you anticipated, there is reason to be concerned for an immune-compromised state there as well. How do you treat it? So antivirals can help. It is a virus. It can help short it. Pain medication, skin care, make sure it doesn't get secondarily infected. Exactly. The facial nerve. It's technically one nerve, but do you remember that it has 3 branches? So actually the facial nerve, it can kind of go to just one of those 3 branches as well. Does the branches go 1, 2, and 3, or A, B, C? I don't really remember off the top of my head. 1, 2, 3? Does it start 1 at the top and 3 at the bottom? Okay. Right. I know it kind of branches, right? If it affects the top one or the middle one, we have to be aware of involvement of what other organ? The eyeball. Yeah, the eyeball. Either from just straight contact, like the mucosa of the eyeball itself was in contact with one of the vesicular secretions, or it hit the nerve root as well. When did you guys do ophthalmology with ET? So you guys remember the fluorescein staining that you can do, look for the dendritic lesions and stuff like that. So that's something that you can do if you're concerned for that. Have you guys heard of the Hutchinson sign? Not Hutchinson molars, the Hutchinson sign. If you have a herpetic lesion on the tip of your nose and nowhere else, on the patient's tip of the nose, and you're pretty confident that looks like herpes, sounds like herpes, zoster, it's herpes virus, I'm sorry. A zoster shingles lesion right on the tip of your nose, you have to assume that it's got the eyeball, and you need to check the eyeball as well. So yeah, very, very, kind of one of those things they like to test on. Hey, this person had chickenpox when they were 5, now they got a rash that just covers up their top left forehead, and there's a weird lesion right on the tip of their nose. What else should you check for? They're trying to tease out the fact that you got to recognize, you got to check the eyeball as well because of the shingles. All right, and severe pain. I know I told you that there are some that don't have pain, and that's true, some don't have pain. But those who, the majority, have pretty severe pain. Just a picture of the dermatomes. The very first one that I diagnosed clinically as a student, the guy was like, yeah, I got these little funny things on my back. And we were in a dermatologist's office. And they had me do the exam, and I was like, it's really weird. It starts in the back, but it ends on his penis. And they were like, what is that? And I finally was like, is is that shingles? And they're like, yeah, it started in the nerve root that ended up innervating all the way down into the groin and the groin and then onto the penis. It's just a picture of how kind of this virus kind of tracks down the nerve root and then works its way towards the nerves all the way down on the skin, and that's where those very deep, painful vesicular lesions are. Immunosuppressed patients, for whatever reason, they have a significantly difficult time recovering from this. Very, very painful. We can diagnose it by a PCR. Visualization is a pretty common way to diagnose it. It's usually a pretty straightforward clinical diagnosis. Here's some pictures of individuals who got the facial nerve impacted. And even though technically the facial nerve is not supposed to go to the eye, it's so close proximity to that mucous membrane, we should check for it. Here's a great picture of that dermatomal pattern. Would you guys say this stays within the dermatome or spreads out of it? That stays in it. That's a great picture, yeah. Kind of pictures of those vesicles on the erythematous base. Dermatomal pattern again, just kind of like follows there. And dermatomes are not as discrete as it looks like in our diagrams. They don't truly follow hard borders. So like all these pictures I show you, they're following pretty straightforward dermatomal patterns. I saw one individual when I was rounding in internal medicine as a student. He had a rash, and on the back it looked very dermatomal. And I thought it was going to be shingles. I was ready to call it shingles until I looked at his chest, and he was like from clavicle to belly button, like just covered in this rash. And so and went across midline. And so, long story short, I found out that he was functionally age-related immune compromised. He was old enough that his immune system just couldn't hold everything in, and the internal medicine doctor I was working with was familiar with him and said, you're right in your workup and your evaluation. We just happen to know this individual tends to have outbreaks like this when he has shingles outbreaks. All right, the infectious agent, the herpes virus, it's presents worldwide, tends to be much more robust and especially problematic in the elderly. And it doesn't have to be a stressful situation that's emotional or psychological. Somebody just gets sick, their immune system might take a hit. They're tired and from lack of sleep, it might take a hit. And then those moments where those immune systems that's not at full strength, that zoster can come down that nerve root. Person-to-person contact, droplet or airborne, and even vesicular fluid. So if there's direct contact with the vesicular fluid, it could potentially transmit that way to a non-immune individual. Just like we talked about varicella. Pregnant ladies, we don't want them to have it. A lot of times, this happened a lot to me if I had a fellow medical provider who was pregnant and there was a rash coming in that sounded zoster's-like. They would always ask some of the individuals who were not pregnant, hey, will you trade patients with me just that way I have to decrease risk of me catching something while I'm pregnant. We would always work with them and stuff like that. You want to do your best to help individuals who are pregnant to not get exposed to this. You do have universal susceptibility if you're not previously infected, and then of course, like I said, the body doesn't actually become immune to it, it just kind of puts it in check, walls it off, sticks it in that dorsal root ganglion and tells it to stay there, and then it looks for an opportunity to flare up. Varicella, zoster, Ig, immune globulin, if you can start that, if somebody needs help, the immune globulin can help that. I've had this question a couple times, so I'm going to talk about it for a minute. Anytime you see a capitalization Ig, it stands for immune globulin, right? Is that a vaccine? It's not. It's a treatment for somebody who actively has that disease. We are taking some type of immune fluid that has the immune antibody complexes into it and giving it to the individual to help their own immune system fight it off. So there are people who can get the vaccine for certain conditions as part of a post-exposure prophylaxis, but we're not giving them immune globulin. And I say that because sometimes those words feel like they can overlap, and we'll be giving them at similar times for similar things. But recognize that Ig, anytime you see that on the end of it, like in this case we have VZIG, varicella zoster immune globulin. That's not the vaccine to it. This is somebody who actively has zoster, has the shingles rash, they're hurting from it. It's early enough in the course that if they are impacted enough, or maybe their immune system's weak enough, that we could potentially consider giving them immune globulin to help their recovery process. Probably the most common immune globulin I have seen given is rabies immune globulin. If you have somebody who has been exposed or potentially exposed to rabies, vaccine series, post-exposure prophylaxis is very important in that case, and then potentially a rabies immune globulin if there's significant concern to it. When I was stationed in Louisiana, for whatever reason, the population there loved to get close to rabies, and I felt like I was treating rabies all the time. Acyclovir and Shingrix. Shingrix is the vaccine. Acyclovir is an antiviral that can be offered to somebody with herpes zoster. Here's an individual child who was exposed to zoster in utero. All right, just a couple more. And I already texted Colonel Heater, told her we were almost done, so she may get started early with you guys. So if you guys want that, I can tell her to hold off if you guys need a long break. Erythema infectiosum. A lot of times you'll hear people call it fifth disease. And these individuals are babies, are typically kids, and they have a really bright red cheek, and they'll describe it as a slapped cheek appearance. It looks like somewhere along the line, someone says, that looks like that kid just got slapped in the face, because it's such a bright, red, robust, infectious response to the skin of the cheek. Parvovirus B19 is the causative agent, and yeah, it's called fifth disease by a lot of people. So if you ever hear somebody, and typically it tends to be kind of the older school people in the hospital that call it by these older names, but you will see it on a lot of tests and certification exams where people will refer to it as fifth disease instead of erythema infectiosum. Fever, headache, runny nose, rash, that only sounds like everything we've talked about so far, right? But in this case, you have such a significant facial erythema, it's really, really robust, and they say that it looks like somebody got slapped in the face. Clinical diagnosis, because that rash is so prominent, anti-parvovirus B19 IgM antibodies would be positive if somebody had it and we were doing an evaluation for it. Treat symptomatically. NSAIDs can help them kind of recover from this. But for the most part, they'll recover on their own with this one. Of course, they could have some complications, anemia, thrombotic, thrombocytic purpura, and some glomerulonephritis and hepatitis are possibilities. Not super common though. Typically pretty well recoverable. Roseola infantum, also known as sixth disease, comes from HHV6, human herpes virus 6. There's an abrupt appearance of rash at defervescence, or like that start to recovery. For whatever reason, this one can come with a fever high enough that gives them seizures. So if you have somebody who's got this generalized pink macular rash on their trunk, high fevers, and then seizures along with it, that might put roseola infantum or sixth disease on your differential. The complications here, myocarditis, encephalopathy, and meningitis. So it's the central nervous system, the muscles of the body. Clinical diagnosis, you can look for anti-HHV6, and we treat them symptomatically. Zika, this one gained a lot of popularity, was it 8-10 years ago, somewhere in that range. It's a mosquito-borne virus, but a couple of unique things about Zika. You really don't want a pregnant individual to get Zika, and males who got Zika can have it live in their testicles for quite some time. And so it is possible even for a female to get exposed to it through semen, through intercourse, because that Zika virus was living in the testicles of the male partner for quite some time. Similar to dengue fever, much more worse consequences for the offspring, and there have been some United States outbreaks of it. And then specifically, if people were travel to endemic areas, and that tended to be where we were at, we would ask people if they had traveled. There was a travel history screening questionnaire when we were worried about the Zika outbreak. Acute onset fever, maculopapular rash, it's itchy, conjunctivitis, and arthralgias, most of the time asymptomatic. If you do have some type of asymptomatic patient who is pregnant and was traveled to an endemic area, testing for the IgM or the antibody, is reasonable. There's really not really great treatments for it. Some complications, microcephaly and Guillain-Barré. You definitely don't want the kiddos to get that. And then other complications, ocular findings, macular pigment mottling. The macula is located in what part of the body? Eyeballs. What specific part of the eyeballs? On the retina. And the macula is very important to what part of your vision? Not color. No, not peripheral. What's opposite peripheral? Central vision. It's the center focus of vision. And if you ever run into somebody who has macular degeneration, they'll call it, it's maybe just age related or whatever, that central vision becomes distorted, so it might be fuzzy or swirly on them or whatever, and so those individuals will compensate by learning to kind of use their peripheral vision well, and so they can never actually look at what they're trying to look at. They have to kind of reteach themselves to use their peripheral vision and compensate with it. I randomly got paired when I was golfing once with an older guy, and he was just crushing me like old guys do. And he was like, man, it's so hard to golf once you got macular degeneration. And I was like, just time out, dude. I'm 20, and you're crushing me as an 80-year-old with, and you can't even see the ball? He's like, no, man, it's real weird. It's not like this like swirly S shape. And I'm like, I hate you so much. But, any golfers?
Oh yeah.
Couple? I love golf. Pebble Beach this week? All right. Aspirin and NSAIDs. It's recommended to avoid it because of possible hemorrhages. However, if you read that bullet, it says so far there don't appear to be bad associations with major hemorrhage, which means somebody's using it to know that or not. So it's really not a great necessary recommendation, no treatment plan. A lot of symptomatic treatment monitoring of it, and then definitely avoid mosquitoes if at all possible when you're in a known endemic area. And that's our viral illness lecture. Tried to work through it quickly for you guys so that you guys can get some study time back. I'm going to do my best to have, I know I keep promising that, I hope I don't